السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم آه، بتكلم عن الترانسبلانت ورك اب. طبعا هناخده في فترة كده بحيث اديك كل التريكات بتاعت الورك اب. ان شاء الله هنديها لك بالتفاصيل وبكل التريكات بتاعتها، بحيث انت ما تحتاج تبص في كتب ولا تاخد اي تبص لاي سورس تاني وكده. ان شاء الله نحاول نجمع لك كل التريكات والحاجات اللي بنستخدموها فعلا على ارض الواقع، ونتكلم عنها بالتفصيل إن شاء الله في محاضرات مبسطة وفيديوهات قصيرة بإذن الله. نتوكل على الله. كل المحاضرة دي الغرض منها طبعا أنا هعرفك إزاي إن شاء الله تبدأ تعمل ورك اب لكل المرضى اللي عندك في الدياليسيس في وحدة الغسيل. إيه المطلوب منك بالظبط وبطرق بسيطة إن شاء الله، وإيه التريكات اللي تاخد بالك منها، وإزاي تحضر ال الورك اب بتاعك وتعمله شيت في الآخر إن شاء الله، بحيث إن تكون مظبط المريض بتاعك من اي تو زد وما تكونش مزد اي حاجه. طبعا عمل ديسكشن كليرلي مع المريض مع والكونسنتات وكل الكلام ده كله هنتكلم عنه بالتفصيل. لعدم الاطاله بس نتوكل على الله ونبدا. ترانسبلانت ورك اب اند ايفالويشن. طبعا اول حاجه انت بتعملها طبعا في الشيت بتاعك عموما البيشنت انتروداكشن. البيشنت ده عمره كام سنه؟ مثلا انا حاطط لك مثال، مثلا 69 years old male patient with industry renal disease. industry renal disease secondary ليه؟ يعني ايه البرايمري كidney disease بتاعه؟ secondary to diabetes hypertension or whatever or GN whatever the type of GN. مين الدكتور اللي عمل لك ريفيرال؟ لو انت كدني لو انت ترانسبلانت نفرولوجيست بتكتب بريفيرد باي كذا كذا، او البرايمري كير بروفايدر بتاعه والديت بتاع الفيزيت بتاعتك ان المريض جالك في اليوم الفلاني. اول حاجه طبعا بتاخدها من المريض الرينال هيستوري، دي تحطها عندك كده. تاني حاجه في الشيت بتاعك الرينال هيستوري. وات از ذا كوز اوف اندوثيليال ديزيز؟ وات از ذا داياليسيس موداليتي؟ هل هو هيموداياليسيس ولا بروتينيال داياليسيس؟ وبدا من امتى ستارت داياليسيس ستارت ديت؟ واني كومبليكيشن ويز داياليسيس اور نو؟ لو على بروتينيال داياليسيس ان ريسنت بروتونايتس اكزيت سايت انفكشن اور نو؟ بيشنت اون انتيبيوتيك اور نو؟ وات از هيز quality on dialysis? What is doing with dialysis? Dialysis any malfunction is any complication like blood clot or thrombosis or an infection or fever or infection. All this you should cover this part during you taking history from your dialysis patient, either hemodialysis by the complication of hemodialysis, especially if patient has caster-related blood stream infection or patient with peritoneal dialysis with PD peritonitis. Take care from this 2 point. And is patient have this? Some patient have some problem with catheter thrombosis or uh, frequent thrombus or clots in his catheter. Just take care from this patient. You should send all thrombophilia screen for him, and we'll come all to this point in future. And residual urine output is really is important question for your patient. If you will miss to ask your patient about residual renal function is a big problem for you. فانت لازم تسال العيان ده بيجيب يورين قد ايه في اليوم عموما، بحيث ان انت مثلا لما تروح تشوف العيان ده بعد السيرجري تبقى عارف ان هو كان عنده اصلا ريزيدوال رينال فانكشن ولا بدا هو يجيب يورين. معظم العيانين بيبقوا انيوريك، فلما تلاقيه جايب مثلا 1 لتر معناه ان جود سيرجري وجود جرافت فانكشن وكل تمام. لكن ما يكونش العيان بيجيب 1 لتر وتروح الريكفري روم وتلاقي العيان طبعا ما فيش يورين. طبعا هنا لازم تحط فول ستوب وتوقف وتعمل ستات الترا ساوند to rule out post-operative surgical complication. Blood transfusion, try to avoid any blood transfusion for any patient in dialysis, especially patient willing for kidney transplant, because this will make your patient sensitized and antibodies in his blood, and this will affect his chance to find kidney donor if this you have deceased donor program, or also this will make this patient have sensitized for any kidneys after that and high risk for rejection, and he will need a lot of immunosuppression and dilemma after that. Better to avoid blood transfusion except if less than 70 his hemoglobin and with symptomatic anemia. Otherwise, just try your best to replace his iron, vitamin B12, folic acid, and stop any nephrotoxic medication plus either erythropoietin, whatever available with you, especially RNSP. Current medical problem. Yes, ده زي الميديكال هيستوري بتاع المريض او السيرجيكال هيستوري included both The patient in this disease secondary to hypertension controlled in this medication, type 2 diabetes on this medication, and you have this patient diabetic nephropathy on dialysis or not, preemptive or not, anemia of CKD and last hemoglobin, and is a treatment on iron, RNS, or folic acid, or B12, or whatever. Medication and allergies also is like everything is here is tricky in transplant. Don't miss anything in transplant because medication and allergy is also another big problem if you miss any part from this. Like medication, like this patient, for example, is nabixaban or some patient on Plavix or clopidogrel. If this patient came to transplant for diseased kidney or day of surgery, they book at the date and someone missed the patient to mention the patient need apixaban conversion or patient on Plavix, he should go home. No way. But now we are just try to do conversion for patient on apixaban. We just make this, you can give just some plasma complex. We'll come to all this, how to convert this direct oral anticoagulant and warfarin. Warfarin is the easy one because you will give vitamin K and maybe you'll give fresh frozen plasma if needed, or just a PCC before transplant. We'll come to all this protocol in future. But for now, just keep your eyes to mention all this alarming medication like anticoagulation and any drug allergy because some patient may be allergic to ceftriaxone. The plan to give, for example, dapsone or pentamidine or atopacone. But for dapsone, we should screen for G6PD. Take care from this drug allergy and anticoagulation, antiplatelet, and all medication like Ramipril or ACE or ARBIS. All this medication should be stopped before transplant because this little bit will not help the kidney recovery after transplant. Only the medication from we can continue prescribing only beta blocker. Otherwise, most of the other medication should be stopped. And if the patient diabetic, just sliding scale insulin and just will follow after transplant or insulin IV drip, especially for type 1 diabetes. It's different protocol. Will come to all this in future. Family and social history, especially for family history of kidney disease like renal stones, because sometimes this is a cause of this we see a lot before, but not now. Especially if you have recurrent renal stone, recurrent UTI, just you should screen all the family for any genetic abnormality like primary hyperoxaluria, for example. And polycystic kidney disease also, you should ask for family history of any cerebral aneurysm. And already, especially for this case, polycystic, we should do MRI brain to rule out any cerebral aneurysm. And we should ask for other cardiovascular problem, diverticulosis, or the frequent stones, also frequent UTI, hypertension. All this you should be asked for any patient with polycystic kidney disease. Marital status and the children to be sure this patient have family or no for future after transplant, and anyone have kidney problem or no. Smoking, alcohol, you should just mention to your patient, any patient to smoke, just during your transplant clinic, just inform your recipient now if and encourage him. You should لازم تشجعه ان هو لازم يبطل التدخين، لانه لازم تشرح لهم. انت تخيل انت جبت صندوق مغلق وحطيت فيه الكليه والصندوق ده كله دخان عموما، يعني حاول توصفه له بالطريقه ديت بحيث ان هو بيحصل سيفير فازوكونستريكشن وبيحصل طبعا دامج للدونر كيدنيز وذ ذا تايم ديكريز الكواليتي والسرفايفل بتاع الكدني افتر ترانسبلانت. Employment, but to be sure the patient have insurance for medication and is able to resume his work after and cover his medication cost after a transplant. Functional status, this independent need assistance. This is important. I don't know, because our countries already we have good family support, but here they looking for this to arrange after discharge if this patient needs support at home, nurse to go home, to organize his home for his safety after transplant. He's able to walk, he's able to go to washroom, he's able to take showers, he's understand that he take his medication. Otherwise, they will arrange all support for patient before discharge home. Review other system. حتة ريفيو اذر سيستم ده انت بتمسك العيان من فوق لتحت كده، من كل يعني كل اللي يجي من تمسكه من شعر راسه لغايه رجليه كده. تبدا بس عندك الكواليتي اوف لايف، الانرجي، الابيتايت، سليب، اكسرسايز توليرانس، بالذات how many kilometers he can walk, how many stairs he can go up, down, and any chest pain, any short of breath, any orthopnea, any proximal nocturnal dyspnea, any edema, any claudication, any urinary symptoms, he's voiding urine well, any burning urine, any problem with his urine, any red urine, any cloudy urine, any bad odor in his urine, he's making urine or no, and his bowel motion is regular or no, his body weight is stable or losing weight, and you should just go to review all system of the body. For physical examination, you just go ahead to the vital signs, especially for blood pressure and others. Blood pressure in young, like if you find 180, 190, and CKD, and he discovered just by hypertension and CKD, should do all screening for secondary hypertension before transplant. And as we know already, all hypertension patient on dialysis is fluid until proof otherwise. Just adjust your target weight and try to maximize ultrafiltration to reach the target weight. BMI, usually they now just increasing. Before 30 contraindicated, now 30 can go to transplant surgery, and also 35 and reaching out to 40 now. They can go if this just only not abdominal obesity like muscular man or whatever. And some young patient try all measures but failed, but some agree to be transplanted and won't. Problem after transplant will take long time for healing. And long hospitalization and delayed wound healing, maybe infection. All this should be discussed with the patient and his family. And GVB during examination, is patient overloaded or no. Heart lung examination, as we know already, we should examine this abdomen to be sure the abdomen soft lax, and there's not abdominal obesity, no organomegaly, no ascites, and no previous scars, or this will make the surgery difficult because adhesion after surgery, and no lower limb edema with intact peripheral pulsation. Don't miss this one. This is the most important, his lower limb and his feet, because some patient came by, some chronic diabetic patient came by foot ulcers and heading under socks تحت الشراب بتاعه. لازم تفحص العيان وتشيل الشراب خلاص من على رجله وتطمن ان مفيش فانجل انفكشن، مفيش ألسرز، مفيش. ولازم تحس دورساليس بيديس او posterior tibial، ولازم تحط ايديك على الفيمورال بالس بايلاترالي. دول مهمين جدا، لازم تذكرهم عندك في الاخر اكزامينيشن. اللور ليمب اكستريميتيز، نو اديما، نو دي في تي signs redness, inflammation, hotness, or different size of both lower limb, because some patient came for transplant workup. He just waiting long time, and he just came for examination during admission for diseased kidney. And when I am examining him, I found his left lower limb is double size of his right one. And we just did Doppler stat and Doppler revealed DVT, deep vein thrombosis, and patient went home and started anticoagulation for that. Other patient, I saw him also, and we just remove his socks، شلت الشراب بتاعه، فلقينا big ulcer. He need just skin transplant or graft transplant, not only kidney transplant. We send him home also. Take care from this. Other patient, elderly, chronic diabetic, also with no peripheral pulsation. You should just be sure with the surgeon he's okay or no, and discuss the risk. Now sometimes they open and they found just calcified iliac vessels, can't be anastomosis, and the patient just to close his wound, and the kidney sometimes will be discarded because long ischemia time now. Laboratory investigation, usually just we are doing a routine renal panels, whatever, serum creatinine, urea, sodium, potassium, and bicarb, or oral glucose tolerance test, fasting, and 2-hour postprandial hemoglobin A1C, to just predict how incidence this patient will be at diabetes post-transplant, CBC, and coagulation. To be sure his hemoglobin in target above 100, at least keep your patient on dialysis above 100 at least. No leukocytosis and no thrombocytopenia. If platelet is low, just repeat without heparin on dialysis. If still low, just revert to hematology. Maybe this patient need bone marrow biopsy. Coagulation also, sometimes PTT is high because most of the patient need heparin on dialysis. Just repeat again without heparin on dialysis, and see if he's still abnormal. Just revert to hematology. Also lipids with baseline iron studies, special iron saturation, because if iron deficient, better to replace before transplant. Calcium, phosphorus, magnesium, to BTH, alkaline phosphatase, to be sure this patient not need parathyroidectomy before if he's calcium is high, phosphorus high, beta H high, alkaline, just do system EB scan or ultrasound for each thyroid if you need parathyroidectomy before, or we just try medical treatment if it's not controlled. We know the indication of parathyroidectomy. We discussed all this before in all the videos in my channel. And transplant workup, histocompatibility, especially ABO compatible. And the most important, HLA mismatch. Usually, just still some centers still we are using for ABDR now at least, and in Toronto we are using for this 12 already, 12 HLA antigen. But at least ABDR to just to give you idea how much mismatch for this patient to play with his immunosuppression after, and CBRA, how much his CBRA to predict monitoring after transplant if this creatinine rising suddenly or something happening, sensitization like blood transfusion, previous transplant, pregnancy. All this also will give you idea your patient sensitized or no for immunosuppression induction as we discussed already. على فكرة المحاضرات بس عشان هتبقى كلها مترتبة على بعضها عشان ما نعيدوش تاني. السنسيتايزيشن لو العين بتاعك هايلي سنسيتايز طبعا في اي تي جي اندكشن وبازيلكسيماب اندكشن، هنتكلمنا على الكلام ده. عندنا الانفكشن سكريننج خاصة السي ام في ده important, the most important CMV and EBV, because as any one mismatch means donor positive and recipient negative, they will need 6 months valganciclovir for both. Hepatitis B should be immune above 100, hepatitis B surface antibody above 100, and if hepatitis B core antibody positive, either for donor or recipient, maybe you will need entecavir for 1 year. Hepatitis C should be negative also. HIV and syphilis and tuberculosis, TB skin test should be done for all patients. Malignant screening, usually we're starting by just fecal occult blood in stool and fecal immunohistochemistry, and if anyone positive, will go direct to colonoscopy before transplant. We should, in female, we should also in male, we should do prostatic specific antibodies, and if it's high, you need urology clearance by MRI or cystoscopy or biopsy. Other female pap smear should be done, and mammogram should be done before transplant. This is a malignancy screen in summary. Cardiology, the first thing we'll do ECG if normal, we'll do echocardiogram if normal. Also, if the patient is risk like chronic dialysis or diabetes or hypertension or whatever, just we'll do stress test. If it's normal, that's enough for here. But if some patient with some abnormal stress, he should go to angio and it should be cleared by cardiology if you will stop at any stage, because some young people just will do ECG or echocardiogram or both, and that's enough, and to be cleared by cardiology, especially if young and no multiple comorbidities. Imaging chest X-ray should be done routinely to rule out any malignancy or any infection or any abnormal pathology. Abdominal ultrasound also should be done as a screening for the liver, for spleen, for kidneys, for abdomen. Iliac Doppler you can do if you suspect this patient may be some atherosclerotic, especially in his iliac. And CT iliac blood vessels without contrast should be also done for your recipient as a screening and dialysis to be sure he's no more calcification in his iliac arteries. And finally, you will discuss the risk benefit of transplant. Yes, when you are sitting with your patient in the clinic, in summary, just to tell him what is the benefit of transplant now, what is the benefit and the risk now. You should make a balance. What is the benefit? Improve quality of life. And for example, dialysis give you 25% of the normal kidney function, and transplant will give you 50% of the normal kidney function because you're receiving only one kidney. And this 50%, the kidney transplant also is the best treatment. I mentioned all this in the first lecture in the transplant introduction, but just to remind you, transplant is the best treatment, but is not cure for the kidney failure. And the benefit of transplant, 50% of the normal kidney function, it will improve your quality of life and also better graft survival, freedom from dialysis, free for fluid and the food, no more restriction like before transplant. Socially, it will be better, travel will be easy. What is the risk now? Risk of kidney transplant, and we have perioperative risk, DVT, pulmonary embolism, bleeding, infection. Everyone knows all these details. And long term, we have rejection, infection, malignancy, metabolic complication. We'll speak about all this metabolic complication in future separately, like post-transplant diabetes or hypertension or whatever. Just will speak all this, and a lot of infection post-transplant PK, CMV, and parvovirus will come to all this rejection, either T cell mediated rejection, antibody mediated rejection, malignancy, and non-malignant skin squamous cell carcinoma is the most common post-transplant, and we'll come to speak all about all this in future. Donor option, either you have live donor, is better outcome, shorter wait time, no more waiting time for deceased donor in wait list, and is better and longer survivor, better graft function. Deceased kidney, longer wait time with the graft function, especially if we have deceased donor after cardiac death. ECD kidney, you remember ECD from the first lecture I spoke about transplant introduction. You remember, put in your mind, what is the ECD kidney? Extended criteria donor kidney, either the donor above 60 years or less than 60 year plus hypertension or CKD creatinine around 133 or CVA stroke. It will be just also a little bit shorter graft survival, but better than waiting on dialysis. Exception distribution, we discussed this in the first lecture already. Small risk, very low risk for transmission infection for donor. Just came from a motor vehicle accident, and we don't know the full sexual history, physical history or examination. This mentioned like exception distribution donor, and you should sign consent for that. Hepatitis C NAT, either NAT negative or positive, they accept this now because we have this Maveret as a treatment for this hepatitis C. Some center given 7 days, some other given 1 month, and the other given 2 months. This is according to agreement with multidisciplinary team with our transplant infectious disease. Outcome expectation, rejection around 5 to 10% in the first year, rejection rate. Delayed graft function around 30 to 40% deceased donor, 1 to 5% in live donor. This is because ischemia time already is shorter in living in comparison by deceased one. Now rejection rate 5 to 10% in the first year. So we are giving high immunosuppression doses in the first year plus induction during the surgery. Delayed graft function 30 to 40% with deceased donor, especially the deceased after cardiac death, not after brain death. Brain death is sometimes working like better than living donor. Living donor delayed graft function maybe 1 to 5% because shorter ischemia time. Graft survival or half-life of your kidney transplant. Usually, you should mention to your recipient in the clinic, deceased donor 10 to 12 years, but living donor maybe 18 to 20 years. But this is not the rule for all, but sometimes we see deceased or living kidney 40 years and 30 years and sometimes 50 years working without any complication. This is different from patient to patient already. To conclude, just see, during the first clinic visit, you will have some bending issue, maybe sometimes not seen by cardiology, sometimes not seen by anesthesia, sometimes not seen by social workers, not seen by the urology or transplant surgeon. All this should be arranged from the first clinic visit. Sometimes he missing CT iliac Doppler or iliac Doppler, whatever we should recommend in our first letter or first visit to complete all workup to be cleared by cardiology or infectious disease as whatever the situation if your recipient. And after that, you will finalize either your patient candidate for transplant or high risk for transplant, and the patient should be consented either for standard or extended criteria donor, exception distribution, hepatitis C, NAT, positive kidney or no. All this should be explained, but everyone here from ACD or AXD or hepatitis C is better than waiting on dialysis, especially for this. Maybe sometimes the kidney working well without any problem, and this one because recent treatment better to keep your patient waiting on dialysis just and expecting a lot of complication during dialysis. لغايه النهارده هنكتفي. دي كانت مقدمه او مقدمه بسيطه جدا عن خاطر ازاي تعمل ورك اب للترانسبلانت. خلينا بقى المراحل اللي جايه نتكلم عن كل التريكات اللي هتقابلك في الترانسبلانت ورك اب في العياده، وازاي تشرحها للمريض وازاي تبقى خبير، ازاي تتعامل مع حالات ترانسبلانت عندك في الدياليسيس وتجاوب على اي سؤال للمريض بتاعك. ولا تنسونا من صالح الدعاء بالتوفيق والسداد والصحة والعافية. ولا تنسوا دايما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. والسلام عليكم ورحمة الله وبركاته.